for this very nice introduction. Thank you very much, and it was very well pronounced, my name.
Yes, I know. Can you tell me now how can I pronounce your name?
Czech.
Okay. Thank you.
So it was very nice. So thank you very much for this nice invitation to be here, to be an invited speaker as your society, at your Society of the Egyptian Nuclear Medicine. So I'm feeling very honored to be here and to tell about some details in the conventional molecular imaging. And we have to remember, before we are getting into this theme, we have to know that the American President Obama said some years before, yes, we can. And of course, this is a sentence for us nuclear physicians, yes, we can. We can do a lot of things. We can perform diagnostic steps. We also can perform therapeutic steps, and we have to know what we can do and what we have to talk to the other colleagues what we can do. So let us go inside this theme of neuroendocrine tumors. We have at first to know that the diagnostics of neuroendocrine tumors is often very easily because they are functionally active. That means they show a lot of clinical symptoms, and of course, if you're performing a blood analysis, a lot of increased tumor markers will be detected. But on the other side, we have always small tumors. So we have the problem of localization of them. Okay, we have on the one side the morphological imaging like ultrasound, like CTs, like MRI. But the disadvantage is these are localized imaging procedures, and they are proceeding because on the size of those tumors. And on the other side, we are the nuclear medicine part of the whole medicine. We can present functional imaging. Of course, we can perform scintigraphy and SPECT-CT, and of course, PET and PET-CT. And these are imaging procedures where we are performing a whole body imaging. We have a more higher sensitivity than the radiological imaging procedures. This we have to know. And this imaging procedures depends on the receptor expression, and in the second step on the size of the tumor. So in one-stop shop we can perform a whole body imaging, and we can localize the primary tumor and of course the metastasis or the tumor burden. We can detect the tumor progression or regression in a therapeutic regimen, or we can select the patient for the best treatment he should have. Before we start with the real nuclear aspects, we have to know something about the sensitivity of all the methods we have talked about. One famous method in the oncological diagnostics is the FDG PET-CT. But in this paper, it was published that this method has the lowest sensitivity in detecting of neuroendocrine tumors. Why? Because well-differentiated neuroendocrine tumors shows no significant uptake, and vice versa, poorly differentiated tumors shows a very high uptake of FDG, but this is a smaller group than the other ones. So the sensitivity of FDG PET is very small, but you have to use sometimes the FDG PET in combination with the octreotide scan I will show you at the end. The best sensitivities we can find and were calculated for the combination of octreotide scintigraphy, meaning octoscan, and in combination with CT, for example, in image fusion technique SPECT-CT. This is very important to know that we have enough sensitivity in detecting such tumors. Now we have to understand what we can image and how does it work. If you're using the normal scintigraphic systems and gamma camera systems and SPECT CTs, we have two tracers. They are common. One, he is detecting the somatostatin receptor expression, meaning octreotide. And of course, you can detect also the amine metabolism of chromaffin cells of the neuroendocrine tumors, meaning using MIBG scanning. Of course, you have nearly the same detection system if you're using a PET or a PET CT. Of course, we can detect the receptor expression using, for example, gallium DOTA-TOC or DOTA-NOT, DOTA-TATA, and so on. And of course, we can show the amine metabolism also by using FDOPA. But these are very small amounts of PET-CT samples, and they have to produce always the radiopharmaceuticals by their own. So it's very complex in the PET-CT area to perform these diagnostic steps. And the third important information is that the scintigraphic and PET tomographic results are not only results with a diagnostic intention. They always have a therapeutic intention too. What does it mean? Yes, we have some nuclear physician therapeutic steps we can offer the patient using the receptor expression also. We can give yttrium DOTA-TOC or DOTA-TOC or lutetium DOTA-TATE for the therapy. So if you have a positive tumor detected by the receptor expression using octreotide, you also can offer the patient the way of radiopeptide therapy. This is very important, this combination. And also, if you have an MIBG positive tumor, you also can offer an MIBG therapy. These are very important information. So let us have a look on the somatostatin positive tumors. We have to remember, if you find in the scintigraphy using, for example, octreotide, a positive tumor, you have the option of therapeutical intention. This scintigraphic way of acting is very easy. We need no pre-medication. We use a standard dosage, and sometimes you have to give laxative because of clearing up the intestine. And it is very important to perform a whole body scintigraphy. Whole body, not a part only of the body, but a whole body scintigraphy, 4 hours, 24 hours, and of course 48 hours after injection, and of course with SPECT or SPECT-CT to get a high specificity and high sensitivity. Because we know the longer you are waiting, the more the contrast is detected by our gamma cameras in patients with neuroendocrine tumors. And now some words about the octreotide or octreoscan. 2004, it was published that this is a very common and a very good substance, a radionuclide isotope and a radiopharmaceutical that is very stable in the patient, meaning these are the whole body scans up after injection to 76 hours after injection, and you can clearly define the metastasis, the octreotide positive metastasis in the liver of this patient from the beginning up to the end of this detection road. And this means that is a very stable substance, a very stable complex, and this is quality, very high quality radiopharmaceutical. Now, where we can see the indications for octreotide scintigraphy. Of course, we all know the GEP-NET tumors, meaning the gastroenteropancreatic tumors For example, carcinoids, lipomas, glucoconomas. And of course, there are many tumor identities more, like tumors of the pituitary gland, Merkel cell tumors. It is very easily to describe meningiomas. You have to inject, and at the first pictures, 4 hours after injection, you can say this is a meningioma or not. And there are many more tumors. This group of indications is growing. Why? Not because of the high incidence of those tumors, but because of our knowledge. We have to know that every tumor in the body can present neuroendocrine signs. You have to ask the pathological institution and to ask if they can find some signs of neuroendocrine tumor. Then you have the indication for this method. And of course, you always have the therapeutical intention too. If you're looking on the PET ligands, we know octreotide, they will contrast the somatostatin receptor 2 and 5, the other ones also, and we need in first line indium 111 for the scintigraphic methods. Now some examples to show you the results and to show you the discussion based on the results of these scintigraphic method. This is a patient with a carcinoid of the lung. Because of this, an octreotide scintigraphy was performed. You see the whole body imaging. And the question was metastasis of lymph node or not, metastasis of liver or not. And if you are looking at these results, you can clearly define the original tumor, but no metastasis around, so no metastasis of the hilus or mediastinum, and of course no metastasis of the liver. So in this case, you have in one whole body imaging all the information for discussing should we perform a surgery or not, because there are no metastases, and this patient underwent surgery, and afterwards he was healed from this disease. But what we have to discuss if we see such a case like this, a metastatic carcinoid, a patient which shows in the octreotide scan a lot of focal uptakes, not only in the lymph node of the mediastinum, but also liver metastasis, bone metastasis, and the lower back also. What we can do there? Of course, we know all the metastasis of the body. Because of this, surgery is no option for this patient, of course. So we have to discuss systemic therapy, and of course a treatment with radiopeptide therapy is possible in this case, and this was done in this case too. So you can see, you can resume because of a whole body scan with a high sensitivity, what can be done next. This is an example of an intestinal carcinoid. You clearly can define all the metastasis of the lymph nodes and of course of the liver too. We have performed, as I told you before, a SPECT, not a SPECT CT, but in this case a SPECT, to define the metastasis, to localize them. And you can see, if you compare the 4 hours pictures with the 24 hours pictures, that the contrast is raising up, so the sensitivity of this method becomes better and better the longer you are waiting and your scintigraphic or produce the scintigraphic results. Of course, you can use octoscan, for example, also for therapeutic monitoring, because this is a case with a lot of metastasis of a neuroendocrine tumor in the liver. Besides, you can see the same transversal slices of CT. This patient underwent therapy by radiopeptide therapy, and you clearly can see that in this part where we, before the therapy was prepared, found a lot of active metastasis. We cannot see any vital metastasis anymore. In the CT scans you can resume some rests, some tumor rests, but they are not vital, so you can say this was a successful therapeutic regimen. So therapeutic on therapy monitoring you can perform by this method also. And the last example of octreotide scintigraphy is a case of a patient with a neuroblastoma, a recurrence of neuroblastoma. He was, or he underwent a lot of therapeutic regimen from surgery up to chemotherapy, and now there were some signs in the blood of recurrence of neuroblastoma. And because of this, the octreotide scan was performed. You can see the whole body imaging, and you can see that there is a slightly higher uptake of the left lung. We have discussed what could it be. Maybe something like inflammation. We have performed SPECT-CT, and there you can see in the transversal slice that the uptake is diffuse in the whole lung, and if you perform image fusion, you can see that this is an infiltration, a recurrence of neuroblastoma with an infiltration of the whole lung of the left side. So I talk about also of the chromaffin tumors, neuroendocrine endocrine tumors. And there we can use MIBG also. And we always have to remember that this scintigraphic methods are also implemented therapeutical intention. If you have an MIBG positive tumor, you can perform this therapy also. What does it mean, MIBG? This is a precursor of the synthesis of epinephrine or norepinephrine, so we can image chromaffin cells of the group, of the big group of neuroendocrine tumors. Of course, the indication is at first the pheochromocytoma patient and neuroblastoma patient. But as shown before, you have to know that neuroendocrine tumors can show somatostatin receptor positivity and chromaffin positivity, or vice versa. They can show no activity, and of course some tumors with somatostatin receptor positivity shows no chromaffin activity, and vice versa. So this image, this nuclear image investigation has to be performed as a second line, especially for patients with somatostatin receptor negative tumor. In Germany we are performing both scintigraphy to detect all the differentiated neuroendocrine tumor cells also. So the imaging of MIBG is a little bit more complex than of octreotide, because we have to discontinue a lot of drugs like tricyclic antidepressants, because these are drugs which can reduce the uptake of MIBG in the tumor cells of neuroendocrine tumors. Of course, we have to administer in this patient perchlorate to block the thyroid because of free radioactive iodine in the patient because of radiolysis after injection this tracer. And of course, we have also standardized doses we have to administer, and we have also to perform whole body imaging 4 hours, 24 hours and 48 hours after injection, also in combination with SPECT or SPECT-CT. Adverse effects are rare. Sometimes the patient feels sensation of heat. and the effective dose equivalent is nearly 3 millisievert. You know, octreotide has an effective dose equivalent up to 10 millisievert. And if you are comparing this to the normal radiological investigation procedures like CT, there we are producing 20 up to 40 millisievert if you are using contrast media also. So all things are wonderful. So please look at these wonderful pictures also. This is an example of a patient with a resected carcinoid. We have performed 4 hours, 24 hours, and 48 hours after injection the pictures, and you can see that we have a tracer accumulation in the bottom of the right liver lobe. This was the metastasis of this carcinoid. But I told you we are always performing both the somatostatin receptor scintigraphy and the MIBG scan. And in this patient also, here I present you the scintigraphy results 4 hours, 24 hours, and 48 hours after injection of octreotide. You can see also a lot of metastasis, positive somatostatin receptor positive metastasis in the liver. But now it is interesting to compare both results. So at first the octreotide scan and second the MIBG scan, and you can see that they are different. They have different results. One part of the metastasis show an chromaffin positivity. The other metastasis of the liver show somatostatin receptor positivity. So this is very interesting to know because of the therapeutical intention, not only of the nuclear physicians, but also what to use for a chemotherapy or a cold or hot octreotide scintigraphy. Do we have to combine them? This is a discussion that's going on if you have something like this results. The medullary thyroid carcinoma is a typical indication for MIBG. You can clearly define this tumor, also the metastasis in the liver. This was a patient with a multimorbid patient who could not be resected, so an MIBG scan and an MIBG therapy was performed. Now let us have some views into the future. We are knowing, we have diagnostic and therapeutic intention of the scintigraphic imaging procedures as I have shown. The one thing is the radio-guided surgery. This field of acting is growing. Why? Because you know all the sentinel lymph node scintigraphy and sentinel lymph node resection using gamma probes. So every bigger hospital has a gamma probe, and you can use the same gamma probe for radio-guided surgery of neuroendocrine tumors also. This is a very interesting aspect. And of course, you have heard, I have seen it in the timetable, a lot of things about the cell therapy. Of course, this might be an aspect too, because this is a therapy who can focus on the metastasis of the liver of neuroendocrine tumors. And of course, we have to know that SPECT-CT will be the gold standard in the detection of neuroendocrine tumors. And after lunch, I want to present you the double isotope technique also to combine the bone scintigraphy and the octreotide scintigraphy in one procedure. And of course, we have to know that PET-CT will get new tracers, but you have to produce this by your own. So let us focus on the radio-guided surgery. After injection of octreoscan, you can, and if you have, of course, if you have positive tumors, the intraoperative detection of tumor spread by gamma probes is very easy to perform. We have a high definition of lesions, and this is have a high influence of intraoperative staging. It's very interesting to for the surgeon to know where he has to cut something more as before. So this is a case of a patient with, and is very quick to perform. If we are looking on the third therapy, we have to know that neuroendocrine metastasis of the liver shows a very good tumor perfusion. And because of this, we can use third therapy to make a therapy of those metastases. And we have to know that very often neuroendocrine tumors produces liver metastasis. So the third is a potential therapy, and this can be added to the radiopeptide therapy, to chemotherapy, to all other therapies, and this is an advantage. This is a case of a patient with some metastasis in the liver shown by a radiographic perfusion scan. And this is a patient before third therapy, and this is a patient after third therapy. There's no perfusion, so no vitality anymore. So at last, I want to focus on PET-CT. We have talked about the gallium DOTA tox. This is a known tracer of PET-CT, but you have to produce this tracer by your own. If you want to perform scintigraphy, you can buy, for example, MIBG or octreotide to perform staging in this patient. We have heard something about the FDG scan in those patients, and the F18 DOPA has to be produced also by your own. This is an example of a gallium-68 PET-CT scan of a patient with a carcinoid, which presented carcinoid syndrome with an unclear primary and a lot of liver metastasis. The primary could be focused on the intestine. We have to know, as I talked before, that low differentiated neuroendocrine tumors has a high uptake, and vice versa. If they are well differentiated, the FDG uptake is very low, so it's better to get a scintigraphic result. And we have to know also that the tracers, the radiopharmaceuticals for PET tracers, have a high contrast. It is a very fast diagnostic. 1 hour after injection you have the results, and we have a high resolution. But you have to discuss it. If you are looking on these pictures, comparing a PET scan with an octreotide scan, you can say, yes, the contrast is better, okay. Maybe that you can find 2 or 3 more metastases, but do we have very clear result for the patient? Does it change anything in the therapeutic decisions? So this discussion is still going on, and the most knowledge of detecting of neuroendocrine tumors is using octreotide scan. So at least I want to show you where you can use FDG PET in combination with octreotide scintigraphy. This is a patient with a metastasis of the liver of a neuroendocrine tumor, and we have performed the indium 111 SPECT CT. You can see there's no uptake, so no specific uptake. There's no somatostatin receptor positivity. So afterwards we performed the FDG scan. We saw a high uptake of FDG, so we could resume that this is a poorly differentiated net, and this has influence on the therapeutic way of acting, meaning we cannot perform the radiopeptide therapy or a cold octreotide therapy. We have to think about a chemotherapy or something else. And on the other side is this patient with a high-grade uptake of indium octreotide. This is a tumor, it's clearly definable, and on the other side we can see there's no uptake in FDG PET, so this is a patient where we can discuss a radiopeptide therapy or something like this. So let me conclude that the tracer uptakes, if we use FDG PET in combination with octreotide, helps define the phenotype, the risk assessment, and of course the way of therapy. So let me summarize that octreotide, of course, also MRBG scan is a well-known, available radiopharmaceutical for molecular imaging. I have shown you that we can visualize different tumors or different parts of the tumor in one patient. And so you have to think about different therapeutic modalities. And it is important to know that we have a very high sensitivity of our whole body scans using octreotide and MRBG. And we can answer all the questions of diagnosis, staging, treatment monitoring, restaging, and so on, so that I can conclude that for NET patients, nuclear medicine offers reliable diagnostic tools for especially the whole body imaging, SPECT and SPECT CTs, and the gold standard is the octreotide scintigraphy using whole body scan and SPECT CT. And we have to remember that all these scintigraphic methods have also a therapeutic intention. So at the end, I want also to conclude, we cannot say only yes, we can, but also yes, we scan. Thank you very much.
Thank you. I think the message was very clear, and I think everyone now have the message that for med therapy you have to go to medium stereotype.